the last live surgery of the session. That is a case of high myopia, which will be shown by Dr. Rohit Parkash. Are we ready in the OT?
We can't hear her.
Are we ready in the OT?
Yes, they look ready, but we can't
We are ready
hear.
in the OT.
Okay, can we start?
So we have Dr. Rohit Prakash with us, a humble soul who radiates warmth with every smile, who will show us how to handle a high myopia case. The axial length of this patient is 31.65. He will be using the Centurion Phaco machine and will operate on low IOP settings, and will be using the Zeiss microscope. Over to you, sir.
I would like to thank Dr. Naren for this opportunity, and I'm humbled to be here to see such a beautiful setup. I think Bangalore has a very good tradition with Dr. Shrignesh, and here, they are excellent, setups. So I've been asked to showcase a patient who is a high myope, and the IOL power is turning around to minus 0.46. So we would be implanting a zero diopter intraocular lens, because we want that with this, sensor from Johnson & Johnson, because that would help reduce the incidence of posterior capsular opacification. And if by any means we have to do any posterior YAG laser capsulotomy, that will prevent herniation of vitreous into the anterior chamber and cause sequels. The site of incision which I would be using would be a temporal site of incision. Why a temporal? Because that gives me the opportunity to have better access, and it's a limbal incision. I am not going to go in for a long tunnel because I don't want to have a difficult access, but at the same time I do not want to have a short tunnel. So this is an appropriately sized tunnel which I have been able to create. Next step is, it's a grade 3 cataract. At this point of time, I feel that what I'm going to do is, I'm going to do the trypan blue staining. So I do it under air. Then I use a 30 gauge needle. Under air, trypan blue staining is going to be done, because this gives me the advantage of a closed chamber, a consistent contact of trypan blue to the anterior capsule. I give some time for the air to be there and trypan blue to get stained, and now I am trying to take it out. Once that is done, the next step is introducing a viscoelastic, which in this case is going to be a viscodispersive. I would try not to over deepen the anterior chamber. The next step is creating a calibrated side port incision, because I do not want unstable anterior chamber settings, more so in a patient who happens to be a high myope, because these fluctuations can be detrimental in long run. This is a 25 gauge needle. So that has gone in. So this is around 500 microns. So this 500 micron is calibrated to the side port chopper which I would be using. I'm going to create a rhexis. Puncture is there. Hold it. My endeavor at this point of time is that the capsular axis sizing has to be such that it should be covering the optic. The capsular axis should cover the optic. I am not going to do any exaggerated hydrodissection. Can you hear me?
Yeah, you're audible, sir.
Slight lifting, so I'll not bother about that. Visco again. So I'll be using a balance tip can you see my machine settings? The machine settings which I would be using would be an IOP would be around 30, that side. And that is because I'm trying to create a situation in which there is less infusion of fluid into the anterior chamber, less deepening of anterior chamber, and less incidence, and less incidence of lens iris diaphragm retropulsion syndrome. So the chopper which I would be using would be the chopper which has been showcased by the great Dr. Mohan Rajan. So now this is, no, I need the other chopper, ma'am. The pointed chopper. I'm going in. Where is it? I think I made it. Yeah, there it is. I've gone in. So I'm giving some time because I do not want at this point of time for there to be any, wound burn. Now I'm trying to focus it. I'll try to create a central, is it sculpting, sir? Sculpting? I need procedure 4. Make it chop. Hold it, lift it, go full thickness, and chop it. So I'll rotate it again because it's a very hard cataract. Trying to chop it. So grade 4 cataract, chamber very deep. Good, can you put some visco? Is it clear?
Yes, Dr. Rohit, we are able to see.
Very hard cataract. I'm taking my time. Yeah, this is the first chop which I've been able to create. Now I'm going to rotate it. Hopefully life is going to be better. Yes. Again a chop. Chamber is deep. Cataract is hard. Total separation. I think I've been able to create, this is slightly bigger. Lift it, chop it more. Now I think there will be a central core which has been free. Can you make it now quadrant removal? It is not freed from all sides. So I'll rotate it. Rotate it, rather chop it. Now I will try to separate it fully at different planes and at different places. Separate it. Not fully separated. Go on rotating it. Rotate it more. The click is that we have to separate it before we pull out one. You know, these myopes, the nuclear fragments are harder than what you expect. Still, ये क्या हो रहा है? Can you give me the other chopper now? Is it focused? Yeah. It misses. ये क्या होता है सर? So I'm going to separate it. Yeah, it is separated.
So my question to the panelists, any tips for handling high myope patients with this grade of cataract? Any tips
Use
for
the
No one has come out.
Use the Myloop.
No, it will
You'll
be
finish by
easier.
now. See, for beginners only, I mean, it's quite safe to use. The other
No, no,
thing
no.
is, when you're
No.
chopping, see, every hard cataract has a sweet spot. It's just like when you hit a 6 in
Yeah.
cricket.
Can you
or
see
when
this?
hit
It
a
has totally separated.
200 yards in golf, you can actually feel that. And then
Separate
there's
it
a sweet
again.
spot in the bat, and it will go for a 6. Similarly,
Yeah,
the nucleus
now
has a sweet spot, which is
you can
slightly
easily take it
deeper than
out.
the center. So you have
ये
to
क्या हो रहा है सर?
impale
मिस क्यों हो रहा है?
the tip. You cannot hold with vacuum.
Huh?
You have to bury deep enough,
Why is
impale,
it
go up to the sleeve. So this is like 4.5 millimeter thickness. So you have to be at
What
least
happened
2
is-
millimeters, 2.5 millimeters into the nucleus.
Now,
And your chopper has to be at the same level, and then it will split. You have to do the lateral separation because the
so now the
fibers are very
last
tenacious.
2 pieces are there. They are totally
Excellent going,
separated.
Rohit. Well done, doing very well. I think it really requires a brave heart surgeon to be doing this. Wonderful. Yes. I think one tip here would be like the
Have you
most.
seen what I have done? What I have done is I have created an epinuclear shield now. So that is going to protect the posterior capsule in an event of now.
Sir, would you consider just replacing, replenishing some OVD there at this stage, or because it's a very dense
I'll use
cataract?
chopper. I'll use epinucleus as a shield.
Okay.
The only rescue for the surgeon at this is that always going to be a deep anterior chamber. So the cornea is far off, a couple of miles away from that's our. If it's a hypermetrop with a shallow anterior chamber, that is a brown-black cataract presented by Harshul Tak. You know, those cases in a shallow AC and a dirty cornea would be bad. The only favor is a high myope is a great advantage because you have so much place to work for.
So I have created an epinuclear shield. Can you see that?
Yes, Rohit, we can see the.
Can you see?
Yeah.
Can you see the epinuclear shield which I?
Yes, sir, it's clear.
Now what I'm going to do is, as Dr. Deepak had said, I'll re-inflate it, visco.
Deepak, 2 more things we need to tell the audience here is, one is it's a high myope, so the tunnel length should be adequate. It should not be too much into the anterior chamber.
Yeah.
And since it's such a high
Either
cataract,
it not.
continuous irrigation on the
Yeah.
wound should be there to prevent the wound burns.
A
Same.
very valid point.
Sa-
So
la-
the trick to get a good separation is the trench which you do to bury it, that has to be deep so that you get access to the deeper core. Just like Dr. Harshul was
Yeah.
demonstrating, the central core which you create. The trick here is to get a good grip. So one of the clues is bury until the sleeve, entire tip should be buried inside it. So no metallic part is visible, entire whatever 1.5 millimeter buried into the nucleus, then that ensures better holdability there.
And for beginners, when you're removing the
You know, the
last
most
piece, stop, put viscoelastic, even reduce the parameters. You can reduce your flow rate so
Yeah.
that you don't have any surge.
Yeah, you know, another important thing is, yeah, I think it's done. I'm coming out with irrigation off.
I think
So that is another important.
Just want to raise one point, Shri
but
Ganesh.
even the tip which is there, it should be exposed more, especially in this type of hard cataract.
Yeah, yeah.
Usually you expose 1 to 1.5,
Yeah.
but I would go for at least 2 millimeter exposure so that I get
Yeah.
a good bury into
Iska
the,
sleeve there.
because these nucleus are very hard.
You know
The
what?
diameter is.
What is the test? What is the test whether the grip is there or not? Because when you try to chop,
There
if the
should not be
nuclear
any
fragment
torsional
moves,
movement. If there is torsional
Yeah, yeah.
torque of the torsional movement of the nucleus,
I think
that
there is
means
hardly
you are
any.
not
Can you
buried
give me
deep
the
enough.
lens?
No, you can
Yeah,
actually
let's-
combine the vertical with the horizontal. You bury deep and go
Horizontal,
vertical,
yeah.
and then go around pull it up a little, and then go around the equator, and combine that with the horizontal as well.
With
And
your
in a
chopper,
high
I think
myop-
it will go deep.
I know, but yeah, I demonstrated that. In high myop, what I would suggest is every time you come out of the eye, inject visco. You don't want the chamber to shallow, because the reason
Higher
is
risk of
So that is why,
endophthalmogenesis
you know,
can occur,
if
and you know
you are
that
using
can
low
cause the
IOP,
retinal detachment postoperative.
if you are using low IOP, so there is no, you know, it doesn't happen.
So, but it was a brilliantly
now I-
demonstrated surgery. I think a round of applause for Sir for taking up such a difficult case.
A very tough case and a very
Yes.
well done job, Dr. Rohit. Great surgery.
Well done, Dr. Rohit.
I think
And I think this three-piece lens is overall diameter also is bigger, so it sits,
Yeah, it has to be.
centers
Yeah,
better
yeah.
in the large bag.
Absolutely correct.
Rohit, your opinion on primary posterior capsulotomy in such cases, would you or would you not encourage?
100%, 100% no. Even if it happens to be a thick one. Because you do not want primary capsulotomy to be done, because that is, you know, and that too in a high myope, definitely no.
Also, the bag is a little lax, in high myopes. Very
Yeah.
difficult to do posterior capsulorhexis. And if we cannot do it, your entire battle is lost.
You can use a femto. Bucardic,
I think the IOL is well centered.
cases.
The next important thing is what should be the timing for the other eye. That is another very controversial, because if the patient is used to using a contact lens, you can postpone it, because you want things to, and if by any means a PVD is there in the other eye or in this eye, you can then, you know, hasten the second surgery.
Another point is when you're doing these very high myopes, the biometry, I always aim to have a residual myopia of about 1.5 to 2 diopters, because if you make them
Yeah, I
emmetropic,
try
they
around
are
minus-
miserable.
Yeah,
They are
yeah.
miserable because they
Minus
miss the
because they are
angular magnification and they are not able to read. Even if you give
Yeah.
them a +3, they are uncomfortable reading.
Because they are used to, you know, throughout their life. And you know, you have to take time for the incision to seal, because you know, the sclera is elastic in these patients, thin. So that should, you know, and you have to be clear that it is definitely, you know, sealed before you move on. You should not rush at this point of time.
Thank you
I
so
take
much.
my time, I release. Yeah, I think I'm
Thanks,
done.
Rohit.
Any question?
One more point with myopic cataract, any high myopia, even with not such a bad nucleus, is generally a nuclear cataract. It's a hard cataract. It's not so much at
Yeah.
the periphery. It's always tough in the center. Any myopic cataract.
Most of these black cataracts are seen in myopes.
Thank you so much, sir,
Yeah,
for
because it's a privilege.
demonstrating such
It's
a
privilege.
complex case in an easy manner. I thank the expert panel for their knowledgeable insights.